everybody, and welcome to what we're calling Raja and Neil's FASD Book Club. This is the fifth in our series, and we are really pleased that you're all here to join us. We have a wonderful speaker today, Dr. Anna Hanlon-Dearman from the University of Manitoba. I'm going to let her introduce herself further, but she's an expert in FASD and has been working in this field for many years, and it's just a real honor, especially as she's joining us from Manitoba, where it's currently about 7:30 a.m. So we really appreciate that you're here today. As you know, most of you should know, this is what we're doing with this book club. We're taking a book that was edited by Professor Raja Mukherjee and Dr. Neil Aiton. The book is called Prevention, Recognition, and Management of Fetal Alcohol Spectrum Disorder. And they've agreed to allow us to help bring the book to a wider group of people by these little mini lunchtime sessions. And we'll start off with the introduction, with the presentation, and then we'll stop the recording at that point, but we'll have lots of time for Q&A. And if you could put your questions in the chat, that'll make the Q&A session, which is a bit tight, it'll make it go a little bit faster. So without much more fanfare, Professor Hanlon-Dearman, over to you.
Excellent, excellent. All right, so thanks so much, Sandra. And hello, everybody. My name's Anna Hanlon-Dearman. I am a professor of pediatrics and child health at the University of Manitoba, Canada. And I'm also the medical director, and I'm a developmental pediatrician of the Manitoba FASD Centre and Network. So that's the center, we call it the Keystone Province in Canada, and many call it the heart of the continent. So I'm very pleased to be here, and I'm very pleased to have everybody here today on a Friday afternoon with what is probably either your lunch hour or a little bit after your lunch hour. I thank you. I'm very grateful for you taking the time to come and listen. This is where I work. I like to show where I work because it's always nice to have a little bit of context where everybody's from. I'm a pediatrician. The building that you see there is actually a cookie factory. It's the Mr. Kriski's cookie factory in Winnipeg. It's now our clinical space, and you can see our atrium there at the bottom. We like to be welcoming to kids, and the atrium that we have is very sensory friendly. So there's visual sensory things, auditory sensory things. And we also, not in this picture, have a quiet room for kids who might find this just a little bit overwhelming. We have a nice quiet space for kids and families to sit and enjoy. So the reason I wrote this chapter and the reason why I'm talking with you today, and I'm going to try not talk for too long so that I have a chance to answer your questions, is really, as you know, FASD is very, very common. And there's really three reasons that I want you to remember as I'm talking. One is FASD is common, FASD is everywhere, and FASD is often hidden. And it's very important to be able to recognize FASD not only at all ages, but in a variety of settings, and for us as clinicians to think about it, and for families to understand that they can bring this to their clinicians or to their support people at any time across the lifespan, because it's really incumbent on us to work with you. One of the other important reasons why I wrote this chapter is that there is an impact on assessment, and I'll talk about that later. How we assess a baby is different from how we assess a preschooler, how we assess a school-age child, and how we assess an adolescent or an adult. And as kids, and I often refer to the individuals as kids because I'm a pediatrician, so forgive me. As we assess individuals at different ages, we also have to remember that as kids get older, often life happens, and many individuals, if not most individuals, have at least one other long-term medical or mental health condition. Many have experienced trauma, and many are misunderstood in their behavior and approach to life because of it. So it's really important that we understand what FASD looks like at all ages. And finally, the third reason is that when we know what we are dealing with, that informs the supports that everybody needs, the supports that the individual needs, their family needs, and their community needs for the individual to be really successful. So just, you know, the percentages here aren't as important as recognizing what we know about how prevalent FASD is, not just in different settings, I apologize for the mistype there, but also to let you know that not only prevalence in schools, but for us, children who may be in care, but across various studies around the world, children who are in inpatient psychiatry, and then adolescents and adults who may be in prison systems, there is a prevalence that's much higher than the oft-quoted prevalence of that's sort of a general, you know, 3.6% in school populations, up to 4%, or sometimes even the lower percentages of 1, really doesn't reflect the breadth of higher percentage areas, and also the breadth of ages that we find people. So it's really important to think about this. And this picture is that often showed picture of what how babies develop way early, when they're just developing from just a few little cells to a baby in the mom's womb. And the reason I put this in is to remind us that all of those physical features of FASD not only change when a baby's in the womb and develop and depend upon the exposure of alcohol and the timing and the amounts. We talk about that frequently, and I'm sure others will talk about that more in some of these sessions. But it's also important to think postnatally, past this picture, the physical features of FASD in those who have physical features change with time, and often they rather soften with time. And so it may become harder for clinicians to recognize and see the physical features when they're present. But remember, for most individuals, physical features aren't in fact present. And so then it brings us to this other frequently shown picture of the brain, showing us the various areas of brains that may be affected by alcohol prenatally. But these are important to think about when we're thinking about assessment of brain, because the brain in fact grows and changes and develops over time. And what is available to us to assess when we're looking at an infant or a very young preschooler is much different than when we're talking about a school-age person or a young adult. And I'll talk about that in a second. So Susan Astley Hemingway kindly has provided this picture online, and you can see the picture and how the physical features may look different, and in fact may not be all that recognizable to general public as we talk about the symptoms of FASD over different ages. So let me maybe go through some of those symptoms. In infancy, in newborns and infant, what we often see are various symptoms related to excessive arousal. And what I mean by that is infants can be very difficult to sleep, to feed, to settle, to manage, and all of that difficultness. And the reason I put that in quotes at the bottom there is because one particular researcher actually referenced a measure of infant difficultness. And if there's any of you who are mums in the audience, you might recognize that sometimes it can be challenging to look after a baby who just doesn't eat well and doesn't sleep and just can't settle themselves. And what we see clinically is that the tone may change, so that physical either stiffness or floppiness may be there. And sometimes it varies even within the same baby. Sometimes the quality of the motor skills may be apparent. They may be delayed in their motor skills. They may be a little bit less coordinated in motor skills, or in fact tremulous in their motor skills. Very often, and we notice this a lot in infants and younger children, and I think people recognize it less, but probably shouldn't, is that atypical sensory responsivity. So how an infant relates to their environment in terms of light and sound and touch. Infants can be exquisitely sensitive to different parts of of their environment. And it can be really challenging to figure out in a tiny nonverbal little person what it is that's really bothering them or they're reacting to. And of course, infants may be showing that global developmental delay that we often see. As kids get to be preschoolers, we still see that atypical sensory responsivity, but sometimes we see it both in terms of more sensitive as well as less sensitive. And some of the less sensitive parts may be seen as in delayed auditory processing or delayed oral sensory things like young children who may chew beyond times where we would chew because they're just not noticing or responding as well to what it is they're chewing. I had one little guy who chewed right through a metal tennis racket, and that's how he put himself to sleep. You know, they can be very different in the way they respond to things, or they may rock themselves to sleep or headbang themselves to sleep, in fact. And sleep is a whole other discussion that we could have at some other time. That emotional dysregulation that often looks like aggression, but in fact, from a child point of view, often isn't so much they're aggressive. It may just be that they're very active. It may be they're not understanding their environment. It may be that they're being aggressive because they're impulsive and they're having a hard time stopping themselves from doing what they may know they shouldn't be doing. This is an age where you can see that hyperactivity emerging, problems with attention emerging, often language delays. So young preschoolers may be very quiet for a very long time. And when they do talk, their language can be quite disordered. So sometimes they can say phrases or even sentences and other times appear not to understand at all. And because of that, the adults in their world may see some of that as intentional. Why aren't you responding to me? Or why aren't you answering my question? The difficulties with memory often look like young children who are taught a daily routine and seem to have to be taught it again and again newly every single day. Play skills look very young for their age and very poorly developed. And they may in fact have global delays or just adaptive delays in functioning in daily life. As we get to school age kids, this is the age where many clinics often start seeing kids. I will say at our clinic, we see kids throughout the lifespan. We can receive referrals from infants right through to adolescents, and now we're embarking on an adult clinic. But really, many clinics have a comfort level with assessing the school age child. So here's where we see kids who are referred with maybe typical symptoms of ADHD. They may have a lot of behavioral overlay to their ADHD, and it's often described still as aggression, but really what it is emotional dysregulation and frustration. They may be overstimulated. Transitions can be challenging. The literature, and often still I see people who refer to the kids this age as lying, when in fact we could again also have a long discussion about lying, because telling falsehoods is often really a combination of confabulation, telling stories, if you will, to kind of fill in that gap between what they understand and what they believe people to expect them to say. And so the intentionality is not usually there, other than the intentionality to please. But the language, the receptive language problems of kids who don't quite understand what you're asking, but are now old enough to not really want to appear to not understand, becomes very challenging in communication. This certainly has an overlay with peer social relationships and friendships. I'll show you a slide on dysmaturity in a couple of slides. In other words, where kids seem a bit socially less mature than their age, and yet, of course, they're trying to keep up with their peers. They're very it's very possible for them to fall into being misled by peers. I had another little guy who, the brief story was he had FAS and he was, to use older language, and he was convinced by peers when he transitioned to a middle school environment And when it became apparent that he had a bit of a crush on one of the female teachers, he was convinced by one of his perhaps less well-meaning non-FASD peers to write her the words of a song that they told him that she would really like. But of course, it ended up being kind of a rap song that had rather vulgar language in it. And the school, unfortunately, initially thought he had written this and were mislabeling him as having some deviancy. And it wasn't until they understood that he had FAS that he didn't understand even what the words of the song were really about. And all he really wanted was to fit in with his peers and be liked by his teacher. So you can see that there can be a lot of challenges when the behavior that we see is not properly understood in the context. Of course, we see children with learning disabilities and intellectual disabilities at this age. And even in children who have relatively fewer learning disabilities, that adaptive dysfunction is often out of keeping. They just can't walk the walk on a day-to-day basis and apply what they know. I'm going to keep an eye on my time. Adolescents, what we get here is really the impact of executive dysfunctioning. They're often very having trouble with applying, planning, organizing, and regulating behavior. And that gets them into trouble sometimes with the law, with legal systems, or with systems that really expect organization to be applied on a day-to-day basis. So what we have as we get is this picture that I just pulled off the internet. Any of you who work with individuals with FASD can see across the ages, there's a dismaturity or a disconnect between perhaps their language age, their cognitive age, their social age, and their ability to apply this. So I thank No FASD Australia for this picture. And clinically, when we try to put all of this together by our history, by our assessment information, and try and pull it together, we really realize that across the ages, this becomes a challenge because all of our assessment tools that we use across the ages have these very structured, appropriately so, structured assessments and cutoffs, you can see by the red, that we have to meet. And we define all of our brain domains, and while all of the different guidelines at in different countries, Canadian, American, Australian, etc., British, define different brain domains that we need to meet, not all of these brain domains are available to us as clinicians at different ages. So very quickly, at birth, really only some of those brain domains are available to us. And you can see just barely those 3. So that's why we rely on the small head size. But preschoolers can be assessed. And as you get older, different brain domains are more or less available to us. And a different way of looking at this, and again, I'll thank the Australians for this one, is they put this together in one of the documents, and I put the reference there if anybody's interested, but you can find it easily online. Just a way of looking at early years and what we're looking at, and then the number of brain domains and how many more are available as kids are older, and then sort of that added challenge of the mental health problems that they've put in later in adulthood, but I'd argue really is available to you right from preschool. So in the interest of giving you an opportunity to discuss and ask a few questions, I just want to reinforce that we can recognize FASD across the ages from infancy to adulthood, that early recognition is really key to informing a circle of informed support, and getting that assessment and diagnosis is really the roadmap to that. So with that, I think I'll thank you very much for listening to all of my talk, and perhaps I'll listen a little bit to some of your questions and discussion.
And thank you
Great.
so much. That was just fascinating. As I was mentioning earlier, I have an 18-year-old who has FASD, and you were pretty much describing him in almost every one of those slides. I'm going to thank you officially for the recording and end the recording now, and then we will move over to the chat and see what people have been saying over there. So I'm going to end the recording now. Thank you.